So today's topic is radiological manifestations of bone disorders. We know bone is a complex structure which will be having an inner spongy bone and the peripheral area will be of compact bone. The compact bone is formed of an osteon, that is there will be a version canal in the central area which is surrounded by some lacunae with extended canaliculae. So the outermost covering of bone is the periosteum, and the inner spongy bone is actually having trabeculae as well as the marrow space. So when we are thinking about the parts of long bones, it will be having three parts. The central part is known as the diaphysis, and the proximal as well as the distal part is known as epiphysis, that is distal epiphysis as well as proximal epiphysis, and between the epiphysis and the diaphysis there will be the metaphysis. So coming to the bone disorders which are affecting the jaw, it is actually classified in certain subheadings. The first one will be inherited and the developmental type, that is fibrous dysplasia and the fibrous dysplasia which is associated with Albright syndrome, then cherubism, while the giant cell lesions are central giant cell granuloma as well as the aneurysmal boneasis, and the neoplastic variant will be ossifying fibroma and Langerhans cell histiocytosis, and the reaction to injury will be of osseous dysplasia and florid osseous dysplasia. Then there will be disorders which are of unknown etiology like the Page's disease. So coming to the first and the most important form, that is fibrous dysplasia, which was first reported by von Reckling-Hansen in the year 1891. So it is considered as a non-malignant condition where there is an altered bone metabolism. Okay, so what is happening actually is there will be post-zygotic mutation will be occurring. Okay, that will be occurring in the gene that is known as GNAS gene, GNAS gene, or GNAS gene mutation will be occurring, which will result in inhibition of the differentiation as well as the proliferation of bone forming stromal cells. So the cells which are responsible for the formation like bone forming stromal cells will be its proliferation and differentiation will be inhibited, which lead to the replacement of the normal bone with that of fibrous tissue as well as the woven bone. Woven bone is the bone which is having lesser strength than the compact bone. So in the picture we can see there is a inner cell mass that is actually the mutated GNAS gene, and it is proliferating in the second picture, followed by migration of the proliferated gene, and there will be involvement of multiple bones, either one bone or there will be involvement of multiple bones as well as the endocrine organs will be affected. So it is actually when it will be starting when the patient is taking contraceptive pills for a continuous time, and there will be even in pregnancy time. So the facial appearance of the patient who are having fibrous dysplasia is known as leontiasis ossea. That is nothing but the patient will be having lion-faced appearance. Okay, so this is the classical appearance of the patient who are having fibrous dysplasia when it is involving the maxilla. So here you can see a skull image which is showing leontiasis ossea, where the maxillary involvement as well as the mandibular involvement we can appreciate. So based on the number of the bones involved in fibrous dysplasia, it is classically it is divided into two types, that is monoostotic, that is when only a single bone is involved, and the polyostotic when multiple bones are involved. Again the polyostotic variety is again classified into two, that is Jaffe type as well as the Albright syndrome. So when we are thinking about the Jaffe type is nothing but there will be multiple bone involvement along with the pigmented lesions which will be seen over the skin, which is also unilateral. So the pigmented lesions associated with fibrous dysplasia is known as scapholate spots, because it will be having an appearance of coffee. The milk coffee appearance will be there, that is scapholate, coffee like appearance will be there. And in Albright syndrome there will be fibrous dysplasia which is involving the multiple bone, that is polyostotic variety. Along with that there will be scapholate spots as well as there will be endocrine disturbances will be seen. So what are the mutations occurring, or when the mutations are occurring at different stage, different variety of fibrous dysplasia will be seen. That is, when the mutation is occurring in the early embryonic stage, there will be formation of polyostotic variety of fibrous dysplasia along with endocrine abnormalities. That is, mainly Albright syndrome will be seen if the mutation is occurring in the early embryonic life, and when it is occurring in the latest stages of embryonic life, there is only polyostotic fibrous dysplasia will be seen. Then if it is occurring postnatal, that will be the monostotic type of fibrous dysplasia. So when we are thinking about the monostotic fibrous dysplasia, we will start with the subgroup, that is monostotic fibrous dysplasia. It means only a single bone is involved. So in the picture you can see the patient is having involvement of the maxilla. Okay, so in the radiograph, in the skull view also we can see the maxillary involvement, which can be seen clearly here. Okay, so this is the lateral view of the same patient where we can see the involvement here. So coming to the monostotic, the predominance of occurrence in which all bones, that is skull will be involved or facial bones will be involved, then the bones of the hand and legs as well as the ribs will be involved. So the polyostotic type of fibrous dysplasia, that is multiple bones will be involved. So in the first picture you can see even the involvement of maxilla and the frontal bone, which is causing severe facial disfigurement, and in the second pictures what we are able to see is nothing but Shepherd's crook deformity. That is the lateral bowing of proximal part of the thigh. See this area is showing bowing. Okay, that is lateral bowing of the proximal part of thigh. There will be widening of the hip region and it will be giving a hockey stick appearance. Okay, so coming to the next one, that is nothing but Jaffe, the Jaffe-Lichtenstein syndrome. That is nothing but, I told already, the polyostotic type of fibrous dysplasia along with the cutaneous coffee brown pigmentation will be seen. So the main thing of fibrous dysplasia is the pigmentation will be seen unilaterally or ipsilateral side. If left maxilla is involved, the pigmentation will be seen only in the left maxilla. That is ipsilateral side of fibrous dysplasia. Okay. And here you can see the borders are very irregular. See the borders. So it is showing very irregular borders which is resembling the coastline of Maine. Which is this is the coastline of Maine. So see the irregularity. So the same irregularity will be seen in the caveolate spots associated with fibrous dysplasia. So the coming to the radiographic manifestations of fibrous dysplasia. So first of all, the radiographic manifestation should be explained in 4 subheadings. That is, first location, periphery and shape, internal structure, and effect on surrounding structure. So when we are discussing about the location, commonly fibrous dysplasia will be involving maxilla rather than mandible. So when the maxilla is involved, it is twice common compared to mandible, then which is actually the posterior aspect will be involved and it will be seen unilaterally commonly. Okay, so very extensive lesions are only seen bilaterally. So here you can see the unilateral involvement. Here you can see even the involvement of maxilla and the mandible. Okay, so here also you can see the unilateral involvement of maxilla. So coming to different varieties, these are the different radiological manifestation of fibrous dysplasia. Here mandibular involvement, that is also unilateral involvement, we can see. So here the trabecular appearance is actually altered. So there will be short trabeculae, many that is multiple short trabeculae are seen, that is also oriented in different directions can be seen in this area. This is also the same. See. So when we are speaking about the second subheading of radiographic interpretation, that is periphery, it will be actually having a ill defined periphery, that is actually it will be blending gradually to that of the surrounding trabecular bone. Okay, so abnormal trabeculae will be blending to the normal trabeculae, so there will be a clear distinction from that of the normal trabeculae is little difficult. So there will be boundary will be sharp sometimes, occasionally, and even it will be corticated only in case of young lesions. So okay, or early lesions will be having a well defined or sharp corticated boundaries. So this is the case of fibrous dysplasia. Here we can see in the posterior maxilla there is an ill-defined, the borders cannot be appreciated properly, so it will be an ill-defined borders, and anterior margin is actually blending with that of the normal bone pattern. It is actually associated with that of unerupted cuspid, the region will be blending with that of the unerupted cuspid region. So the internal pattern can be considered as a more of a granular pattern. Coming to the internal structure, so mainly the internal structure will be the density and the trabecular pattern will be considerably different. So in this picture you can see, compared to the density and the trabecular pattern of this area, here the density is increased and there is a minute, that is more pronounced short randomly oriented trabeculae can be seen. So it is actually more pronounced in in case of internal structure, that is density and trabecular pattern, we can see more clearly if the lesion is involving the mandible, because in case of maxilla there will be overlapping of different structures will be seen. So it will be more commonly or pronounced or can be seen easily in case of mandible, and while in case of maxilla it will be more of a homogeneous type. So here you can see different form of fibrous dysplasia. See this area. So here the density of the bone is totally changed. There are short trabeculae can be seen. Here also it is giving a granular appearance. Okay. So this is a CT view. In this we can see the clear cut involvement of maxilla. That is also right maxillary involvement can be seen clearly. Okay, so when we are already spoke that early lesions will be having a certain amount of well cortication. So this is the first picture which is showing the early lesion. So here you can see little bit of cortications are present and there is well defined it is. Then later stages there will be radiopacity will be more, and the maxilla and the base of the skull are commonly involved. Then later stages, after the more radiopaque lesion, in certain stages there will be mixed lesion. So in this picture you can see radiolucency as well as radiopacity, that is the mixed lesion. Okay, so coming to the internal structures will be more of a granular, or see this is ground glass appearance or granular appearance. This is like broken glass, this appearance will be seen. See this, it is almost granular or ground glass appearance we can see. Okay, so this is another feature where you can see the fingerprint pattern is clearly seen. So this fingerprint pattern which will be seen in fibrous dysplasia, and the onion peel appearance. See this is having dot appearance, that is the onion peel appearance which is seen in this. This is also the classical features of internal structures of fibrous dysplasia, and there will be in certain cases there will be cotton wool appearance will be seen as an internal structure, and cyst like radiolucencies will be seen, that is will be seen in the mature lesions of fibrous dysplasia. See in this picture also CT image we can see cyst like radiolucencies. Okay, then the last one, that is the effect on the surrounding structure. It will be like there will be small subclinical variety will be having no effect on the surrounding structures, while as it is expanding along its length there will be maintain thin and intact cortex will be there. So cortical border breakage won't be there. The border will be intact. Okay, here you can see the cortical boundaries of maxillary antrum is maintaining. It is maintained, but it will be displaced to the superior aspect, but it is well maintained. So the shape of the sinus will be maintained, and lateral wall involvement will be commonly seen when there is an involvement of the maxillary antrum, and there will be there most commonly their posterior superior portion will be involved, and the floor of the sinus will be showing abnormal bony pattern. So these are the other pictures which is showing fibrous dysplasia. The same here you can see the onion peel appearance and everything. So there will be, the main is another surrounding bone structure is mainly there will be loss of lamina dura will be there, and there will be bone density will be increased, so that means there will be narrowing of the pedial space will be seen. So it will even interfere with the normal eruption of other tooth, and in some cases here as we can see the involved tooth shows hypercementosis. So these are the effect on the surrounding structures. Then in some cases orthodontic therapy will be complicated and the tooth displacement will be seen. Root resorptions are very rare. So the displacement of inferior alveolar nerve is seen, that is actually in the superior direction displacement will be seen. And coming to the differential diagnosis, how to differentiate fibrous dysplasia from other diseases which will be affecting the bone like hyperparathyroidism. That is how we have to differentiate is mainly hyperparathyroidism do not cause bone expansion. It will be bilateral. It will be polyostotic. Paget's disease will be seen more commonly in older age group, and the mandibular involvement, that is also the total mandibular involvement will be seen. Then the periapical simmetal dysplasia, it will be like bilateral. So there will be epicenter will be in the periapical region. Periapical region is the more commonly involved in periapical simmetal dysplasia, and osteomyelitis, that means there will be new bone will be seen on the surface of the outer cortex, and there will be evidence of original cortex with expanded jawbone. So sequestra formation will also be seen around the newborn formation. Osteosarcoma, which will be showing the sunburst appearance as you can see in the picture, and the ossifying fibroma where there will be teeth displacement will be there, that is also more of a convex type of expansion will be seen. So coming to the second one, that is developmental, that is nothing but the cherubism. So cherubism is the one which is actually there are synonyms for cherubism like familial fibrous dysplasia, because it is an inherited form, it is familial. Okay, so it is actually rare, that is also inherent autosomal disorder. It will cause bilateral swelling of the jaw. So the patient will be usually having a cherubic facial appearance. Okay, so the occurrence or inheritance or developmental, this is mainly because of the mutation which is occurring in SH3BP2 on chromosome 4PQ, that is mutation of SH3BP2 gene which is present in the chromosome 4PQ 16.3. Okay, so there will be pathological activation of the osteoclast will be there, and there will be disruption of the jaw development will be seen in the patients. So here the patient actually, it was first coined and documented in the year 1933 by W.A. Jones. He described 3 siblings who are of the same family, that is Jewish Russian heritage family. So the 3 have a similar swelling pattern. Okay, so that increased and it regress of bone lesion will be seen in later stages. So that is around the age of 16 and 17 the bone swelling regressed totally. So actually the facial disfigurement become obvious. In 1943 the children were operated by John's medical team, So they show a hard swelling of the jaw. So after 4 years of surgery, there was no reappearance of the swelling. So that's why he reported it first. And here you can see the swelling or the patient who is having a cherubic appearance or cherubism, that is the mandibular, total mandibular, that is also bilateral maxillary and mandibular involvement. We can see even the orbital involvement can be seen in this picture. In this mainly it will occur from the year 2 to 6 years. So it will be rarely unilateral, most commonly it will be bilateral, and the females are commonly having this cherubism. Eyes to heaven appearance, you can see in this patient, eyes to heaven appearance will be the common, that is angelic face we can call. This is a case of cherubism patient who reported, who is having swelling which is causing facial disfigurement, who is in a younger age group, and later after puberty the swelling regressed by its own. So the radiological manifestation is nothing but first starting with the periphery or first starting with the location, that is actually it will be bilateral, that is both jaws will be affected. So usually when only one jaw is affected, the mandible is the common site. So the lesion usually grows in an anterior direction. So it will be extending almost to the midline. Here you can see the involvement which is seen bilaterally, which is extending to the anterior direction. So here also the epicenter of the lesion are usually in the posterior aspect of jaw. So mainly in the maxillary tuberosity and in the mandibular ramus area will be the epicenter of the lesion. So it will be having a periphery that will be well defined and corticated. As you can see here, it is a well defined periphery will be seen. So the internal structure will be more of a fine granular bone, and wispy trabeculae will be seen. So you can see the trabeculae here, see trabeculae or compartmentation, or there will be compartments will be formed with the trabeculae. So they will be giving the appearance of a multilocular pattern. You see this here, you can see the compartmentation or the trabeculae which is giving it a multilocular appearance. So effect on the surrounding structure is nothing but it will be causing expansion of the cortical boundaries of the maxilla and the mandible. So there will be maxillary lesions, maxillary sinus involvement will be there, and teeth displacement will be there, that is also in the anterior teeth displacement. You can see the tooth displacement completely in this picture. So that will be, and the patient will be having a severe degree of displacement. Tooth bud destruction also be seen in some cases. So the differential diagnosis will be central giant cell granuloma. So here the epicenter will be anterior to the first molar, not bilateral. So in case of cherubism, the epicenter will be posterior most part, that is ramus and the maxillary tuberosity region. By here the epicenter in central giant cell granuloma, the epicenter will be anterior to the first molar and it won't be bilateral. Then and it won't be multilocular. Fibrous dysplasia won't be multilocular, it will be bilateral as well as. Okay, it is multilocular but it is unilateral more commonly. Coming to the next most important form, that is Page's disease. Actually it was first reported by Sir James Page, so it was named like that. That is Page's disease, that is in the year 1877, and actually he named it as Osteitis deformans. So here this is the normal bone, that is compact bone. As I already explained, there will be compact bone, there will be marrow or medullary cavity will be there. So this is the expanded form of normal bone. Okay, while in case of pagetic bone, there will be the bowing will be seen, or there will be hypertrophy will be seen. So there will be thickening. Here you can see the cortical bone is thickened, and there will be fracture which will be occurring. There will be increased vascularity and fibrous tissue will be seen in the marrow. So the vascularity will be increased in the marrow space. Even there will be fibrous tissue will be there in that, and there will be thickening of the cortical bone, which will be causing, sometimes there will be causing of there will be formation of fractures will be seen. And here in the second picture, here the patient who are having Pagetic disease or Paget's disease, the bowing of the long weight bearing bone can be seen. This is the case of the magnified view, in which we can see resorption of the bone with irregular reformation. See the borders, it is very irregular, that is showing the resorption. So it is actually the skeletal disorder which is involving the osteoclast, which is resulting in abnormal resorption and apposition of osseous tissue in one or more bone. Okay, so the multiple bone involvement will be seen. So this is the picture of patient who was having Paget's disease. So here it will be seen more commonly. So this patient is actually old age patient. It means it will be seen more commonly in later, middle and old age patients. And the incidence is actually 3.5%. So the males are commonly affected, that is twice common than the females. And here you can see a skull of a patient with Paget's disease. So involvement of both the bones, that is maxilla as well as mandible, is seen in this picture. So the classical appearance of the patient who are having Paget's disease, that is classical appearance in scintigraphy. Bone scintigraphy is known as Lincoln signs. Okay, we all know about Abraham Lincoln. So the Lincoln sign is nothing but when we are doing bone scintigraphy in the patient, MTP bone scintigraphy in using 99M technetium. When we are doing in the patient, there will be the radio opacity, or there will be the dye will be absorbed to a certain area. Not radio opacity, the dye will be taken in the certain area, like mainly in the mandibular area. So it will be giving an appearance like the Lincoln's beard sign. Okay, Lincoln's beard like appearance will be there, so that's why it is known as Lincoln sign. So it is commonly seen in case of monoosteotic form of Paget's disease. So the mandible will be taking radiotracer uptake will be common in the body of the mandible. So this is the classical appearance. See this is like the beard appearance of Lincoln. That's why it is known as Lincoln sign. So here in this picture we can see there will be usually the ill-fitting dentures are there, or the denture will become tightened in the patient who were having Paget's disease, and there will be tooth displacement will be seen associated with the Paget's disease patient. So when we see the fingers, there will be ill-defined neurological pain will be there. It is mainly because of the bone which is impinging the foramens and nerve canals, that will cause an ill-defined neurological pain for the patient. And there will be, when we are assessing the serum alkaline phosphatase level, it will be more in the patient who are having Paget's disease when the patient is in a osteoblastic phase. Okay, and even the patient will be having an increased level of hydroxyproline level in urine. So the radiological manifestation, there will be more commonly the involvement will be skull, spine, pelvis, thigh bone, that is femur, and shin bone, that is tibia. And it is infrequently it is not common in jaws. So maxilla will be commonly involved than the mandible, that is entire mandible will be involved. So it will be bilateral, and rarely it will be unilateral or slightly greater on one side it will be. So the periphery will be well defined and with laminated cortical boundaries can be seen as we can see in the picture. So internal structure will be more of a early radiolucent resorptive stage can be seen. So as you can see here, and later it will be granular or ground glass or cotton wool appearing second stage. See this, it is cotton wool like appearance we can see. And later on there will be mixed stage. So this is another classical appearance of patient who are having Paget's disease, that is known as Tam-o'-Shanter hat sign. Okay, so it is actually a Scottish hat. This is the hat, Scottish hat. This is known as Tam-o'-Shanter hat. Okay, it is actually named after the character in Robert Burns' poem, who was having the name that is Tam-o'-Shanter. So when the patient is having or Paget's disease involving the skull, there will be widening which will be seen in the diploid space. So there will be widening is seen in the diploid space, and there will be enlargement which will be occurring over the, so there will be widening will be seen, and it will get enlarged cranium. So there will be combined with platybasia. So there will be appearance of the skull which is falling over the facial bone. Okay, as you can see in this picture, it is like so the appearance will be falling, this it is over the skull bone. So this is known as Tam-o'-Shanter hat sign. So this is the another main feature, and when we are seeing the trabecular pattern, it will be linear pattern. You can see the linear pattern which is seen in the mandible. So here also we can see the linear pattern of trabeculae, that is elongated. So here you can see short random orientation of the trabeculae, which is giving a ground glass or granular appearance. And here you can see hypersematosis. Okay, this picture you can see the tooth is having hypersematosis. In this also we can see this. Here the short random orientation of the trabeculae is clear in this picture, and there will be round radiopaque, that is cotton wool appearance we can see, that is round radiopaque structure will be seen. Radiopaque patches can be seen. Then on the effect on the surrounding structure will be, that is there will be early stage also there will be enlargement will be seen, and the outer cortex may be thinned but it will be intact, and there will be lamination will be seen. See, different layers, that is laminated it will be, and maxillary sinus floor involvement is common. So here we can see the hypersematosis for the patient who was having Paget's disease, and the lamina dura is less evident in the patient. Hypersematosis will be more of a irregular type as well as exuberant. So the differential diagnosis include fibrous dysplasia, which is seen in younger age group. Maxillary antrum involvement is common. Focal osseous dysplasia, which will be centered above the inferior alveolar canal, and there will be presence of radiolucent capsule which will be seen around the focal osseous dysplasia, which is not there in Paget's disease. And coming to the metabolic disease, that is there won't be enlargement. Metabolic disease like hyperparathyroidism, there won't be any enlargement of the bone. So coming to the next variant, that is periapical osseous dysplasia as a result of trauma or injury to the bone. There are certain synonyms for the same, that is periapical cemental dysplasia, periapical cemento-osseous dysplasia, cementoma, fibrocementoma, sclerosing cementoma, periapical osteofibrosis, periapical fibrous dysplasia. These are the synonyms for the same. So this cemental dysplasia, that is an earlier term, is used, but it is not used nowadays because there won't be due to the absence of cementum. Actually on histology we can see the cementum. So here there will be localized change in the normal bone metabolism will be seen. That is the replacement of the components of the normal cancellous bone with fibrous tissue and cementum-like material. So there will be abnormal bone formation is seen, similar to that which we can see in the fibrous dysplasia. So commonly it will be seen in the age group of middle age, that is 39 years is the common age group, and it is more common, that is almost 9 times commonly seen in female than in males, and commonly that is 3 times in black than whites. Involved tooth will be vital, and there won't be any history of pain or sensitivity. It will expand very slowly. So this is the case of periapical cemental dysplasia. So here you can see a periapical lesion, but it is not an abscess. It is because the involved tooth is vital. Okay, and there won't be any history of pain or sensitivity. So coming to the radiological manifestations, so the epicenter will be at the apex of the teeth, while very rare cases we can see above the apex, okay, towards the apical third of the root, and it will be the maxillary teeth involvement will be seen commonly, and the lesion will be multiple as well as the bilateral. Here in the picture also you can see there is two lesions are there, so it will be multiple and bilateral, and there will be occasionally sometimes we can see only a single lesion. So this will be later stages, where here it become more of a mixed type of radiolucency. It was completely radiolucent in the previous image. It is becoming mixed in this image, and it is totally radiopaque in the next image, where there is an outer layer or a capsule or a radiolucent rim we can see. So here also the tooth is extracted. The osseous dysplasia is present here, and there is which is surrounded by a radiolucent rim. So here the periphery and the shape, that is well defined, it will be, see, it is very well defined. There will be radiolucent border will be there, that is of a varying depth, surrounded by a band of sclerotic bone. So it will be irregularly shaped, round or oval or irregularly shaped it will be. So this is the internal structure, which will be completely radiolucent in the initial stage, and it will be mixed in the later stage, followed by radiopaque mature stage. So this is the cases for the same. So here you can see fibrous dysplasia type internal bone pattern, that is granular as well as ground glass appearance type of pattern we are able to see, while in this even the internal structure will even show swirling pattern. Okay, here you can see the swirling pattern. So it will even give an appearance of a simple bone cyst, and there will be few regions, that is here you can see cementum like material can be seen. So thus we can differentiate it from the simple bone cyst. So the effect on the surrounding structure is mainly there will be loss of lamina dura, as well as the pedial space will be widened or less apparent, and there will be rare root resorption will be seen. Even there will be hypercementosis associated with periapical osseous dysplasia. So the periapical rarefying osteitis will be the where the tooth will be non-vital. So here we can see the picture of periapical rarefying osteitis. So in benign cementoblastoma also there will be, which is attached to the surface of the root, partially the root will be resorbed, while in case of osseous dysplasia the root resorption is very rare, and there will be well defined peripheral soft tissue capsule, and the internal structure will be showing a radiating pattern. Here you can see more concentric pattern can be seen. Okay, radiating internal pattern can be seen, and which is the wheel pattern we can see in benign cementoblastoma. And in case of odontoma, the occlusal to the associated tooth and prevent its eruption. Here you can see it is actually the cementoma, the odontoma is occlusal to that of the tooth, which is about to erupt, and it is preventing the eruption of the same. So inner aspect will be tooth-like structure we can see, and it will be more defined with peripheral cortex and soft tissue capsule. So the next is florid osseous dysplasia, where the florid cementosseous dysplasia is also a synonym, and gigantiform cementoma, familial multiple cementoma. It is actually widespread form of periapical osseous dysplasia, that is multiple involvement we can see. So there will be females will be commonly affected, and 42 years is the common age group. It is actually find as an incidental finding, because it won't be having any symptoms. So occasionally there will be patient will be having a low grade intermittent poorly localized pain in the affected side, that is very occasionally seen when there is a development of a simple bony cyst, as we have seen in the early periapical osseous dysplasia. So the extensive lesions will be associated with bony swelling. Teeth will be vital in this case also. So this picture we have seen earlier, the simple bone cyst associated periapical osseous dysplasia, and we are able to see some cementum like material for the same. So here the bone involvement, that is extensive lesion which is causing the bone swelling along with florid osseous dysplasia. So the radiological manifestation of the same, that is location will be total, it is actually involving bilaterally either maxilla or mandible. So if only one jaw is involved, it will be commonly the mandible, and the epicenter will be apical to the tooth, same as periapical osseous dysplasia, that will be within the alveolar process and usually posterior to the cuspid, that is posterior to canine it will be seen. And when we are taking the mandible, it will be above the inferior alveolar canal. So the periphery will be well defined, and there will be sclerotic border will be seen, as we are able to see here. It is a well defined periphery as well as sclerotic border is we are able to see. So the internal structure will be mixed radiolucent as well as radiopaque, similar to that of periapical osseous dysplasia. See this, which is associated with simple bone cyst. So here you can see. So there will be a soft tissue capsule or radiolucent capsule can be seen. This is associated with the simple bone cyst. And in this picture you are able to see the cortical plate breakage. Break in the continuity of the cortical plate can be seen in this picture. So here, coming to the effect on the surrounding structure, if it is a very large lesion, there will be inferior alveolar canal displacement inferiorly will be seen, and there will be floor of the antrum will be displaced to the superior direction. As here we are able to see the expansion of the bone here of the mandible. So coming to the differential diagnosis, when it is a Paget's disease, there will be complete involvement of the jaw, and it will be polyostotic type will be common, that is different multiple bone involvement will be seen, and here you can see the laminated appearance. So coming to central giant cell granuloma, the synonyms are giant cell reparative granuloma, giant cell lesion, giant cell tumor, reactive lesion. So this is the giant cell granuloma what we are able to see in this picture. So it is actually 60% will be seen when the patient is less than 20 years of age group, and it will be of a painless swelling. It will be overlying the mucosa with a purplish color, as we can see in this image. It is more of a purplish color. The growth will be very slow, and sometimes it will be rapid. The maxillary lesion will be aggressive, and it will be more of a malignant type of growth will be seen in the maxillary lesion. And coming to the radiological manifestation of central giant cell granuloma, the mandible is commonly, that is twice commonly affected than the maxilla, where the epicenter will be anterior to the first molar in the mandible and anterior to the cuspid in the maxilla. So older individuals will be having a greater frequency in the posterior aspect of the jaws. So coming to the periphery, which is well defined, radiographic margin in the mandible and no cortication will be there. Maxilla will be having a more ill defined periphery, while the internal structure will be small lesions will be not having much of internal structure, while in case of larger lesion there will be granular pattern of calcification can be seen. So it is having a wispy septa or granular septa will be seen in that is also ill defined septa can be seen in the later stages. And there will be, and here you also we can see the septa, there will be uneven expansion or indentation of the expansion with a right angle septa. Here you can see a right angle septa is seen. This is the another picture. Here also you can see the right angle septa, wispy, that is also. So surrounding structure, the effect is mainly it will cause displacement or resorption of the tooth. Here we can see the tooth is resorbed completely, and even there will be loss of lamina dura. Then the inferior alveolar canal will be displaced inferiorly. There will be uneven expansion, that is also with double cortical border, and the outer cortical border destruction will be there in case of maxillary lesion. So the differential diagnosis include ameloblastoma, but it is seen in the older age group. While ameloblastoma will be having a posterior as well as squares curved. Here we can see a curved septa. It is not the right angle septa which will be seen in ameloblastoma. So this is the another myxoma in which we can see sharper and straight septa, but there won't be expansion will be not that much. So aneurysmal bone cyst, that will be a rare lesion which will be seen in the posterior aspect. There will be profound expansion will be seen. While in case of ossifying fibroma, it will be having a more of a granular internal structures, won't be having any septa or wispy septa or right angle septa. Coming to the next one, that is aneurysmal bone cyst, which will be a reactive lesion. So it is actually because of the aggressive benign tumor like behavior. It is exaggerated proliferative response of vascular tissue in bone that is responsible for the formation of aneurysmal bone cyst, and occasionally there will be associated with fibrous dysplasia, central hemangioma, central giant cell granuloma as well as osteosarcoma. The patient will be having, usually the younger age group will be involved, that is lesser than 30 years, 90% will be seen, and females will be commonly having this, and pain and tenderness will be seen on palpation. And coming to the radiological manifestation of the same, that is the patient will be having mandible will be involved rather than maxilla, that is 3:2 is the involvement ratio, and the molar and the ramus area will be involved more commonly than the anterior area. So here we can see an involvement of the mandible. It is actually in the molar and the ramus area rather than in the mandibular anterior area. So the periphery and shape will be like it will be having more of a well defined periphery, and the circular or hydraulic shape we can see here. Even we are able to see the root resorption of the same. So the internal structure will be, initial lesion there won't be any internal structure, while later stages it will be multilocular appearance. We can see septa will be at a right angle position to the outer expanded border. So here in this picture, wispy defined septa we are able to see. So the surrounding structure effect is mainly there will be expansion of the outer cortical plates, that is displaced, as well as resorption of the root we are able to see. And the differential diagnosis is central giant cell granuloma, that is there won't be much expansion which will be seen associated with central giant cell granuloma as much as aneurysmal bone cyst, and the epicenter will be anterior to the first molar in case of central giant cell granuloma. Then coming to ameloblastoma, which will be seen in the older age group, which will be having a more well defined septa. This is a central giant cell granuloma and this is of a ameloblastoma. So the cherubism, which will be having a multifocal as well as bilateral disease. So coming to the next variety, that is ossifying fibroma. So the ossifying fibroma is a type of fibrous lesion in which the bone tumor consists of highly cellular fibrous tissue, that is varying amount of abnormal bone or cementum like tissue will be there, and the female predilection is more, and there will be tooth displacement will be seen associated with the ossifying fibroma. When we are able to, the radiological manifestation shows the facial bone more commonly involved is mandible, that is also inferior to the premolars and molars and superior to the inferior alveolar canal. Okay, so in the maxilla, the canine fossa and the zygomatic arch area will be involved. This is the picture of the same. and the periphery will be more of a well defined, and sometimes there will be a radiolucent. Here you can see a radiolucent thin border. Okay, that is the fibrous capsule of ossifying fibroma, which will separate it from that of the surrounding bone. So it will be having the surrounding bone will be showing sclerotic appearance. Internal structure will be trabeculae will be wispy. Few trabeculae will be wispy. And fibrous dysplasia like granular pattern we are able to see, and even sometimes the flocculent appearance can be seen, that is stuff like here we can see a flocculent appearance, cotton wool appearance can be seen. So the patient will be having a radiopaque cementum like pattern in some cases, more radiopacity will be seen. So the effect on the surrounding structure, there will be an huge expansion of the bone. Okay, so the teeth will be displaced, or the inferior alveolar canal will be displaced. The cortical expansion will be there. So outer cortical plate will be showing thinning as well as, but it will be intact. So sometimes it will grow into the maxillary sinus. Here we can see it is growing into the maxillary sinus intact, but the borders will be intact. So it will be showing a growth, will be showing a differentiation between the ossifying fibroma. There will be a border which is separating it from that of the sinus. So the differential diagnosis include fibrous dysplasia, that is there will be actually gradually it will be bent. There won't be well defined border will be there for fibrous dysplasia. It is gradually blending with that of the surrounding bone. And the internal structure will be more of fibrous dysplasia will be homogeneous when it is involving the maxilla, and it will rarely resorb the tooth. So this is the case of fibrous dysplasia. Cemental dysplasia, which will be multifocal, multiple tooth involvement can be seen, simple bone cyst association can be seen, sclerotic border will be seen, undulated expansion will be characteristics of slow growing cemental dysplasia. Then the Langerhans cell histiocytosis, that is the malignant version. It is also known as histiocytosis X, idiopathic histiocytosis. Langerhans cell disease, it is actually the proliferation, which is actually the abnormal proliferation of Langerhans cells and their precursors. So what is happening is mainly that there are three varieties, that is Langerhans cell histiocytosis. First one is eosinophilic granuloma, that is solitary form. Then Hans-Schuller-Christine disease, that is chronic disseminated form. And lateral severe disease, that is acute disseminated form. So it will be three types, that is eosinophilic granuloma, which is a solitary form, it will be seen in a certain area or a localized area. Then disseminated form will be two, Hans-Schuller-Christine disease and lateral severe disease. Lateral severe disease will be acute form, and Hans-Schuller-Christine disease will be the chronic form of disseminated. So actually there is a newly proposed Langerhans cell histiocytosis classification, in which there is a non-malignant disorders or unifocal or multifocal, that is eosinophilic granuloma, while the malignant disorders are lateral severe disease and the Hans-Schuller-Christine disease or histiocytic lymphoma. So the eosinophilic granuloma will be usually the skeleton which are involved will be ribs, pelvis, long bone, skull and jaws, while it will be involving rarely the soft tissues, and the common age group will be older children and young adults are having eosinophilic granuloma, and it will be seen even it will develop later in life. Quickly it will develop. There will be a dull and steady pain in the jaws, and the bony swelling will be seen, along with a soft tissue mass. Gingivitis will be associated with it, and bleeding, gingiva, pain and ulceration will be seen, and there will be some amount of loosening of teeth as well as sloughing around the teeth can be seen. Socket healing will be difficult if we are extracting the tooth, and there will be single focal or multifocal aggressive disease it will be. While coming to the hand-shoulder crusting disease, it will be multiple bone lesion can be seen, and the patient will be even having diabetes insipidus as well as exophthalmos. And in case of lateral CV disease, the infants which are lesser than 3 years of age will be having this lateral CV disease, and it will be involving the soft tissue as well as bony granulomatous reactions can be seen. Even the patient will be having a disseminated form that will be seen throughout the body, and the patient will be having intermittent type of fever, hepatosplenomegaly will be there, anemia will be there, lymphadenopathy will be there, hemorrhage will be there, and failure to thrive, that is patient won't last, or patient death will occur within a short time. So it will be rare bone lesion. So coming to the radiological manifestation of the same, that is location will be mandible will be the commonest location, then the maxilla and the posterior area will be involved commonly. There will be alveolar variety as well as the intraosseous variety. The alveolar variety, there will be multiple involvement will be there, and the intraosseous there will be solitary, that is mandibular ramus will be involved. So the periphery and shape will be moderately to well defined without cortication, and they will be punched out like appearance we can see. The margins are usually smooth or somewhat irregular. So here we can see the same. So when the alveolation starts, it will be like mid root region of the teeth it will start, and there will be bone destruction we are able to see, that will be progressing in a circular shape. So there will be portion of the superior border of the alveolar process will be involved, that is it will be giving a scooped out alveolar shape. So the intraosseous lesion will be irregular. So here we are able to see the scooped out appearance of the lesion. So the internal structure will be totally radiolucent. See this. So effect on the surrounding structure will be, it will bone destruction, it will cause alveolar lesion, the bone around the teeth will be destroyed, lamina dura will be destroyed, tooth appear will be standing in it, that is floating tooth appearance we are able to see, and there won't be there will be no displacement of the teeth, only minor root resorption can be seen. So these are the cases of Langerhans histiocytosis, which is actually classified, or it can be differentiated from alveolar type, can be differentiated from periodontal disease. So the bone destruction of the alveolar crust and extend apically down to the root surface can be seen in Langerhans histiocytosis. Periodontal disease, the actually the furcation involvement slowly it will be developing, and it will be starting from the alveolar crust fiber. Squamous cell carcinoma, the lesion will be single lesion, as well as there will be involvement of middle or old age. Multiple lesion will be seen along with Langerhans cell histiocytosis. Aneurysmal bony cyst, when we take it, the alveolar crust will be maintained in the same level. While intraosseous type will be, there will be metastatic lesion and malignant tumors are considered as the differential diagnosis, in which there will be an ill-defined borders with no periosteal reaction. So this finishes our bone disorder. Okay, thank you.